Hello, welcome to a brand new medical surgical lesson. My name is Jessie Wheatley and I'll be facilitating this lesson. Please be sure that you have your accompanying notes with you, your textbook ready, and something to write with so that you can follow along with this lesson. Thank you for listening in to this lesson. This lesson is on cardiac rhythms and patient-centered collaborative care. This lesson covers normal rhythms, dysrhythmias, classification of dysrhythmias to include sinus dysrhythmias, atrial dysrhythmias, junctional dysrhythmias, ventricular dysrhythmias, and atrial-ventricular blocks. By the end of this lesson, you should be able to understand that cardiac dysrhythmias are abnormal rhythms of the heart's electrical system, which can affect its ability to effectively pump oxygenated blood throughout the body. You need to realize that dysrhythmias result from disturbances of the cardiac electrical impulse formation, conduction, or both, and can be life-threatening. You need to be able to provide collaborative patient-centered care as an RN using best practices of cardiac electrophysiology in patients with dysrhythmias. You should have a basic understanding of cardiac rhythms at the level of a medical surgical nurse. We will begin this lesson by talking about what's normal. So we will talk about normal rhythms before we switch to abnormal rhythms. Let's talk about normal rhythms real quick. The first one I want to talk about is normal sinus rhythm. Normal sinus rhythm is the rhythm originating from the SA node. If you remember that, that's our dominant pacemaker that meets these ECG criteria. So when you're looking at the rate of normal sinus rhythm, you're looking for an atrial and ventricular rate of 60 to 100 beats per minute. So 60 to 100 beats per minute is normal sinus rhythm. So if you go back to the previous lesson and you look at how to count the rate on an ECG strip and you get 60 to 100 beats, then you know that that's meeting that first criteria. The second criteria we look at is the rhythm itself. We want to make sure that it's regular, so the rhythm has to be regular, at regular intervals. That's what we want to see. The third thing we're going to look at is a P wave. Is a P wave normal? What do we mean by normal? We mean, is it present? Is it consistent? Is it one P wave before each QRS complex? We don't want to see two P waves. So we're seeing one P wave between each complex here. In this manner, we know that's normal. Okay, so we also look at the PR interval. We want to make sure that the PR interval meets that criteria that we talked about earlier. We want it between 0.12 to 0.2 seconds. So this strip right here meets that criteria. We look at the QRS duration. We want it to be between 0.04 to 0.10 second and constant. So we want to keep it under 0.1 second. Really, that's what it is. So if it's that, then we know that we have met the criteria for normal sinus rhythm. When the heart conduction is functioning normally in perfect world, this is what it should look like. Okay, the next one I want to talk about is sinus arrhythmia. Sinus arrhythmia is a variant of normal sinus rhythm. It is resulting from changes in intrathoracic pressure during breathing. So a sinus arrhythmia has all the characteristics of normal sinus rhythm except one thing: irregularity. So it's 60 to 100 beats per minute. We have a P wave that's constant, that's present. It's one P wave after each QRS. And we have the PR interval that meets the criteria, and we have the QRS duration that meets the criteria. The only thing that's not meeting the criteria is the irregularity of the rhythm. That's sinus arrhythmia. Sinus arrhythmia. Let's now talk about dysrhythmias. Dysrhythmias are any disorders of the heartbeat Dysrhythmias can be serious when they affect cardiac function and output. Causes of these dysrhythmias may be a disturbance in the relationship between the mechanical response of the heart and the conductivity. And it may be a disturbance in how the electrical impulse is being formed or where it is being formed. And it may be formed where it should be, or it may be being formed in an ectopic focus. So also, there could be a disturbance in causing delays or blocks, and we're going to talk about all of those. Before we start, however, we want to talk about some terminology you may hear about. That's what this screen is all about. Tachydysrhythmias are heart rates above 100. So this is an example of sinus tachycardia. In a tachydysrhythmia, is going to be a heart rate above 100 beats per minute. Remember that when the heart rate is that fast, it may shorten diastole and reduce coronary perfusion time. And it may decrease cardiac output and blood pressure over time. It's going to cause problems. And it also will increase the workload of the heart, increasing the myocardial oxygen demand. Patients may report palpitations, chest pressure or pain or restlessness or anxiety. They may have a pale, cool skin, or they may have syncope from the hypertension. May lead to heart failure if continues. The next terminology you may hear is Brady dysrhythmias. These are dysrhythmias with a very slow heart rate, or heart rate below 60. So this is an example of a sinus bradycardia. In the sinus bradycardia, you can see how much longer it's taking. This is a VTAC patient, a ventricular tachycardia, and you can see the rate being faster compared to the bradycardia rate here. Brady dysrhythmias can be serious when coronary perfusion pressures decrease. If the heart rate is too slow to provide adequate cardiac output and blood pressure, this is a problem. Patients may need a blood pressure to keep it up at this slow of a rate. They may need a higher pressure because it may affect the blood pressure. Another thing you're going to hear are premature complexes. Premature complexes. Premature complexes are going to be rhythm complexes that are firing prematurely. So it may be firing from an ectopic focus other than the SA node. That's where the firing is coming from, but it's causing a premature firing of the beating. Patient may be unaware that they're having a premature complex, and they may have palpitations. If the premature complexes, especially if they are ventricular, become more frequent, the patient may experience decrease in cardiac output. And I want to talk about, when talking about premature complexes, I also want to talk about what's called allorhythmia. It's an irregularity in cardiac system that repeats itself a number of times. That's where you may see something called bigeminy, and we'll talk about this. Bigeminy is an alternating normal complex with a premature complex. So we have a normal complex and then a premature complex, a normal complex and a premature complex in a repetitive 2-beat pattern. So bigeminy, by 2, it's happening in pairs. Whatever the irregularity of the heartbeat is happening in pairs. Now you can guess what trigeminy would mean. Trigeminy then would just mean that 2 normal complexes, a normal complex and a normal complex, 1, 2, is being followed by a premature complex. And then 2 normal complexes again are being followed by a premature complex. Repetitive in a 3-beat pattern would be classified or termed trigeminy. Quadrigeminy would be 3 normal complexes and then a premature complex as the 4th one. So these complexes that are premature, that are termed trigeminy, bigeminy, and quadrigeminy can be coming from either the atrial, the junctional, or ventricular premature complexes. So we'll talk about those, but I wanted to kind of go over the terminology here to make sure we're good, and I think we are. So let's move on. How are dysrhythmias going to be classified? Dysrhythmias are going to be classified according to their site of origin, whether it be here in the SA node, or it's going to be in the atrial tissue itself, or it's going to be in the AV node, or it's going to be in the ventricular tissue. Dysrhythmias may be caused by disturbance in impulse formation, conduction delays, or blocks. Remember, we talked about that just a few minutes ago. Some dysrhythmias are common and some are life-threatening, and we're going to talk about some of the common and some of the life-threatening dysrhythmias, and we will divide them by where they're coming from. So we'll talk about sinus dysrhythmias first. After we talk about sinus dysrhythmias, we're going to talk about atrial dysrhythmias, and of course after that we're going to talk about some ventricular dysrhythmias. After ventricular dysrhythmias, we're going to talk about some blocks. Okay, let's talk about sinus dysrhythmias first. So sinus dysrhythmias, we need to remember that the intervention from sympathetic and parasympathetic nervous systems is what's responsible for the balance to ensure normal sinus rhythm. So normal sinus rhythm is going to be maintained by those two. An imbalance increases or decreases the rate of the SA node discharging. So the SA node rate discharging may be affected by an imbalance of the parasympathetic and sympathetic nervous system, and those changes can be pathological, and we will see that here in a minute. So the first rate I want to talk about is sinus tachycardia. Sinus tachycardia is sympathetic nervous system stimulation or vagal parasympathetic inhibition that causes an increased rate of SA node discharge. We already talked about tachycardia, meaning faster. So we know that the rate then is going to be greater than 100 beats per minute in this. In children and infants, sinus tachycardia with a heart rate of 200 to 220 may be normal until about the age of 10, but the heart rate gradually decreases, and after the age of 10, the heart rate should be under 100 at rest, and it should not be greater than 180 with exercise, and it should be between 100 to 160 with good exercise, but it shouldn't really go that high. Anytime it goes greater than 100 beats per minute and it's firing this way and the rate is regular and there's a QRS between that is identical between each firing, and the PR interval is normal and of less than 1.2, then it's going to be termed sinus tachycardia. Sinus tachycardia. Initially, sinus tachycardia increases cardiac output and it helps the blood pressure, but when it's sustained and it just kind of keeps going on and on and on and on, it decreases coronary perfusion time. Remember, the coronary artery has to perfuse, and it's going to also affect diastolic filling time and will add myocardial strain because of that. What causes sinus tachycardia? We're talking about normal activity, anxiety, pain, stress, fever, anemia, hypoxemia, hyperthyroid, or physical activity or physical exercise. So if you want to fix sinus tachycardia, we usually don't worry too much, but we fix the underlying cause and the heart rate goes back to normal. Okay, the next one I want to talk about is the opposite, would be sinus bradycardia. Sinus bradycardia, it could be from an excessive vagal nerve stimulation, which is parasympathetic, causing a decrease in SA node discharging. Examples of this is a carotid sinus massage can lower brady you out. That makes sense. And vomiting or suctioning or Valsalva maneuvers or ocular pressure or pain, hypoxia, inferior wall MI. And some drugs such as beta-adrenergic blockers or calcium channel blockers or DIG will decrease the heart rate. Okay, so the heart rate decreases to a rate of less than 60, and the rhythm is still regular. Okay, we still have a P wave after each QRS interval, and then the PR interval and the QRS interval also meets this criteria. So that would be sinus bradycardia. Those are the two sinus rhythms I want to discuss. Let's now talk about atrial arrhythmias. Atrial arrhythmias is when the focus of the impulse that's being generated shifts away from the SA node to the atrial tissue, which acts as an ectopic pacemaker for one or more beats. So the P wave shape differs from normal P waves. The most common atrial dysrhythmias are premature atrial complexes, as you can see here, and we'll talk about SVTs and atrial flutter and atrial fibrillation next. But in premature atrial complexes is when atrial tissue becomes irritable and the ectopic focus fires an impulse before the next sinus impulse is due. So it's premature. The atrial tissue is firing an impulse before it's due. So the premature P may be hidden in the T wave. So you may not have a complete P wave that's coming because the T wave is right there. Okay, look at the T wave very closely to see if you can see if it's premature. PSCs are usually followed by a pause, a compensatory pause. Causes stress, fatigue, anxiety, inflammation. Drugs can cause that. It could also be an MI or other hypermetabolic states. The patient usually reports no symptoms, but they may have palpitations. That's also could be present, but you would see this on a monitor. So you would see that on the monitor. So the rate for PAC is going to depend on the underlying rhythm. The rhythm, it can be regular or irregular. It's definitely irregular whenever a PAC is happening. Okay, that makes sense. The P wave may be present in the PAC, may have a different shape, or it may be a little bit peaked. Okay, the PR interval is, it varies, but otherwise it could be normal, in the normal range, and the QRS complex is going to be also in the normal range. The other rhythm I want to talk about is supraventricular tachycardia. The sudden onset of an SVT is documented in this strip. This is a patient that was in normal sinus rhythm, and then boom, they've gone to SVT. This is a rapid stimulation of atrial tissue due to a re-entry mechanism. One impulse circulates repeatedly throughout the atrial pathway, causing re-stimulation. So when we say re-entry, we're talking about the same impulse circulating and re-stimulating. The heart rate is going to be between 100 to 280 in adults. P wave may not be visible during an SVT. Okay, because it's embedded in the preceding T wave. Paroxysmal SVTs, sudden onset, when the rhythm is intermittent, it initiates suddenly with a PSC and terminates with no interventions. Sustained SVTs, assess the patient for palpitations, make sure that they're not having chest pain, anxiety. Non-sustained SVTs may be asymptomatic. But SVTs do occur in some healthy people, but they really do need follow-up care, and we need to figure it out. And drugs may be prescribed for SVTs. AFib is a very most common dysrhythmia in clinical practice is atrial fibrillation. This is multiple rapid impulses from multi-atrial foci, creating a disorganized rate. So we have two rates here. The atrial rate is between 350 to 650 or 600 beats per minute. That's very fast. The ventricular rate is slow to rapid, about 100 to 300 per minute. The rhythm itself is chaotic. It says irregular, but really it can be chaotic. There's no clear P wave, as you can see in this picture. No atrial contraction. There's no atrial kick, which that's going to cause problems because we're not getting that cardiac output. And irregular ventricular response, and pretty much the heartbeat is just quivering. Okay, this causes a lot of dilation and blood pooling in the atria that can also put the patient at risk for thrombotic event, and it does decrease cardiac output. In your notes, I included drugs you would use And this is a patient that's going to probably can be cardioverted. And I talked about catheter ablation, the biventricular pacing, and surgical maze procedure, which is an open chest surgical procedure where it's usually done when they're doing a cabbage, and they will go ahead and kind of slow some of that conduction down. It's talked about in your notes in pretty great details. Let's now talk about ventricular dysrhythmias. I'm going to mention just a few in this mini lesson. You need to know that ventricular dysrhythmias can be more life-threatening than the atrial ones. Think the left ventricle and the issues that causes by having a dysrhythmia in the left ventricle as far as getting oxygenated blood to the rest of the body. The first one we already discussed a little bit about. It's premature ventricular contractions, PVCs. This is the irritability of the ventricle cells. You see a ventricular compress followed by a pause. We talked about that earlier, and when we were talking about repetitive patterns like bigeminy, trigeminy, and quadrigeminy. Two sequential PVCs are going to be called a couplet or a pair, and multiple or three or more in succession are non-sustained SVTs. Ventricular contractions, non-sustained ventricular contractions. When multiple PVCs are there, the QRS complex may be uniform or unifocal, or have the same shape, or it may be multifocal and have different shapes. PVCs are frequent and may be associated with several diseases, and I mentioned check your notes out a little bit more on PVCs. The next rhythm, dysrhythmia, I want to talk about is ventricular tachycardia, VT, in your notes, VTAC. It is a repeated firing of an irritable ventricular ectopic focus. It keeps firing. It's firing between 150 to 250 beats per minute. Your textbook says 140 to 180 beats per minute, but there's automaticity there. There's re-entry there, and intermittent is called non-sustained VTAC, and it is sustained if it lasts greater than 15 to 30 seconds. The SA node may be discharging, but not polarizing the ventricle in this case. P waves may not be present. You can't really see them. You're not often going to see them. You can see this in ischemic heart disease, MIs, and different things like that. Elective cardioversion is highly recommended for stable VT per ACLS guidelines. There's also drugs you can use. Unstable VT without a pulse will be treated the same way as ventricular fibrillation. Okay? This is a pretty serious arrhythmia. The next arrhythmia we want to talk about is ventricular fibrillation, VFib, which is chaos. I call it electrical chaos in the ventricles, is what I said. There's many irritable foci, impulses being generated in a disorganized manner. There's no recognizable ECG deflections. You can't see what you normally would see. The ventricles are just pretty much quivering and spending a lot of energy, but they're being ineffective at being a pump. There's no cardiac output really with this mess. There's not really a pulse mostly with the patient, though they may be losing a pulse pretty quickly. And there's no myocardial or even systemic perfusion at this point. This is a fatal rhythm, guys. This is a fatal rhythm. It needs to be stopped within the 3 to 5 minutes of it starting. Patients having an MI have an increased risk of presenting with this rhythm. It may occur with hypokalemia and other disorders. When VF begins, the patient may be losing consciousness or may feel faint. They may be apneic and they may lose their pulse, and they may not have a blood pressure or heart sounds. This patient is going to be at a very high risk of respiratory and metabolic acidosis or even seizure. And really worse than that, they are at a very high risk of dying. The priority in this case is defibrillation per ACLS protocol, if that's available. If there's no defibrillator present, we need to go ahead and begin BLS, continue CPR, until one defibrillator or more arrive. And if you have an AED, we probably will need to go ahead and use it. If VF continues after one defibrillator round, we will go ahead and continue high quality CPR and provide airway management. The code team may also do O2 and drugs like vasopressin and epinephrine and amiodarone and lidocaine, magnesium sulfate, alternating with that defibrillation. If a VF is converted to an organized rhythm, then the patient is going to be supported um, in, um, in a unit. Uh, the next rhythm I want to talk about is ventricular asystole or standstill. It's also called a ventricular standstill. There's no ventricular rhythm. There's no electrical impulses to the ventricles. There's no QRS. There's no contraction. There's no quivering. There's no cardiac output. There's no pulse. There's no respirations, and there's no blood pressure in this patient. This is full cardiac arrest, guys. This is the SA node may be firing, depolarizing, but really we don't see even anything really on the monitor. There's not even a P wave. Asystole is a very poor prognosis, not compatible with life. Resuscitation will need to focus on managing airway and getting oxygen to the tissues, and epinephrine and atropine may be used and should be, but really resuscitation attempts should be ended if there's no response after standard intervention, and also if the resuscitation attempt has been the ending has been approved by a physician. Without a physician, you really would probably seek physician approval. You would continue CPR until advanced emergency responders arrive. Evidence-based practice shows that when family is present during resuscitation attempts, it helps them with closure, and it's overall beneficial for them. It's an overall beneficial practice anymore. So the RN should not really focus on resisting the family and kicking them out. The focus should be on supporting the family throughout this time. Let's talk briefly about atrial-ventricular blocks. They may require immediate intervention depending on the type and severity of the block. In this case, the SA node fires normally. Atrial depolarization and P waves appear, just like you can see there, regularly, but the ventricular depolarizations or the QRS complex are delayed or may be blocked completely, or in the AV node or in the ventricular system. The blocks are differentiated by their PR intervals. The first degree block, all sinus impulses eventually reach the ventricles after a delay. Okay, the second degree block is going to be some sinus impulses reaching ventricles. Others are blocked. There's different kinds of second degree blocks, and we're not going to talk about those for this level of learning. The third degree block, complete heart block, no sinus impulses reach the ventricles. A second or independent pacemaker depolarizes the ventricles. So the ventricles are being depolarized by an independent pacemaker. Interventions may depend on severity, oxygen, drugs, pacing, and different things may be done. Now, in your notes, I have included the best practice and different things that you need to remember to assess with dysrhythmias. Be sure to review those. I have also included a list of drug therapy that's commonly used. The Vaughan-Williams classification is commonly used to categorize anti-dysrhythmic drugs, and we have the class 1, A, B, and C. I gave you examples of each one. We have the class 2 anti-dysrhythmics, class 3 and class 4, and I included that in there. I also included other non-surgical management procedures that may be done for dysrhythmias, such as vagal maneuvers and temporary pacing and cardiopulmonary resuscitation, SCLS, cardioversion and defibrillation, and I also have included some surgical management. Be sure to review those as well. Thank you for listening in to this lesson. I hope you have reviewed and gained a better understanding of common cardiac dysrhythmias and other abnormal rhythms of the heart's electrical system. I hope that now you'll be best equipped to be able to provide collaborative, patient-centered care using best practices of cardiac electrophysiology in patients with dysrhythmias at the level of a medical surgical nurse. If you have any questions about this lesson or any of the corresponding notes, please feel free to email me. Thank you and have a wonderful day.